Welcome to GJIA. I'm Judson Thomas. In today's episode, we will dive into the intersection of public and global health and international relations, especially regarding the COVID-19 and HIV/AIDS response and the spread of critical information. I have the privilege to be joined by a remarkable guest, Dr. Anthony Fauci. Dr. Fauci directed the National Institute of Allergy and Infectious Diseases at the National Institutes of Health from 1984 to 2022. In that role, Dr. Fauci was a key advisor to 7 presidents on global HIV/AIDS issues and on preparedness against emerging infectious disease threats. He also served as the chief medical advisor to President Joe Biden. Dr. Fauci was one of the principal architects of the President's Emergency Plan for AIDS Relief, PEPFAR, which has helped save more than 26 million lives throughout the developing world. Dr. Fauci has led numerous research initiatives to bolster medical and public health preparedness against emerging infectious disease threats such as influenza and COVID-19. Now, Dr. Fauci serves as a distinguished university professor at Georgetown University School of Medicine and McCourt School of Public Policy since 2023. Thank you for being here, Dr. Fauci.
Thank you, Judson. It's a pleasure to be with you.
To start, I have a pretty general question. During your time as Chief Medical Advisor to the President and Director of NIAID, especially during the COVID pandemic and HIV/AIDS crisis, what were your experiences working with other countries and governments?
The experience, Justin, was really varied. For the most part, they were very positive. For example, when we were dealing with HIV, which had quite an important impact on the public health in our own nation, the bulk of the cases were in the developing world, about 90% or so, and a very robust, if I use that terminology, 67% was in sub-Saharan Africa. So it was critical in our comprehensive approach to understanding the implications and the extent and the full epidemiology of HIV, together with the design and implementation of clinical trials for interventions like therapies. It was very important to have interactions and good collaborations and cooperations with the Southern African countries, such as South Africa, Kenya, Rwanda, Uganda, and others. And they were just a few of the countries involved. That was critical because when you're dealing with a disease such as HIV, which is global in its implications, the response has to be global. And when you're dealing with a global response, almost by definition, you have to have good interactions with the countries involved. And in this case, it was the African countries. The same holds true for some of the developed countries. For example, from a scientific standpoint, we had very good collaborations scientifically with Australia, with Canada, with the UK, and with several of the European Union countries. So all in all, the experience was very, very positive. Occasionally, there were some bumps in the road, and I'll give you an example of that. Over many years, much of the evolution of influenza emerged from the Southeast Asian countries and the Far Eastern countries, China and Southeast Asia. And for a while there, the collaboration about using the awareness of what the sequence of the prevalent viruses were, some of the countries felt that United States scientists didn't give them the due credit in collaborations when they would describe the molecular virology of a virus. That has been corrected now over the last, I would say, 5 to 10 years. But 20, 25, 30 years ago, there was a bit of a friction, mostly in data sharing when it came to influenza outbreaks. I give you that negative exception, but it really was an exception. For the most part, it was very much what I described to you just a moment ago about the extraordinarily good and productive collaborations between the United States and our Southern African colleagues.
Thank you. So on COVID specifically, what were some of the major barriers for you in discussions with other countries? And do you think that these obstacles hindered our ability in the United States to efficiently help the population reeling from COVID in a timely manner?
Well, I would have to, I think, more informatively answer your question by saying it wasn't really obstacles in the way of communicating with foreign countries. The obstacle was that our system of the relationship between our primary care system, the emergency room, the clinics, and the hospital, and the ability at the national level to get data in real time during the outbreak, we were not as efficient as some of the other countries because our healthcare system is not homogeneous in the sense of the fragmentations of the delivery of the healthcare system. So in real time, we were not always aware as quickly as we could have been aware of what was going on in the trenches, as it were, as the outbreak of COVID was evolving. Whereas in other countries in which we had daily communication with, we got very important information about the evolution of the outbreak, which actually helped us more than it helped them. Give you an example. When the Omicron virus evolved in November of 2021, because of the ear to the ground that the South African scientific and public health colleagues, who were very good colleagues of ours, we've known them for years, they literally immediately let us know about the emergence of a new strain, a new variant of the virus. In fact, I remember it very clearly because it was on Thanksgiving Day of 2021 when I got a call in an apologetic way from one of my South African colleagues who said, I hate to interrupt your Thanksgiving Day, but you really got to get on the phone with us. We have some important information to give you. So they were very transparent and very forthcoming to help us to be ready for the onslaught of the Omicron variant in the winter of 2021. The same held true for the effect of vaccines at the population level once the vaccines were approved. Our Israeli colleagues had a very good connection between the vaccinated population and what the epidemiological effect was. That the original clinical trials, we essentially ran them through Operation Warp Speed. So we had the data at hand. But after the vaccines were approved and globally distributed, we very often had to rely on the immediate access of data from our international colleagues. I mentioned Israel in particular, but the UK was also very helpful to us, as were the South African colleagues. So those were the three countries that literally we were in communication with on a daily basis.
Thank you. I would like to turn now to lab security, which, as we know, became a popular topic following the ambiguous introduction of the COVID pandemic. Is there some sort of international standard regarding lab leak security or lab security?
Well, the answer is yes and no. I mean, there are standards that the WHO has put out. There are standards that the CDC has put out. The only trouble is the enforcement of those can only be enforced by the government that is funding the research that is going on. So we in the United States, for example, there are select agents that require a certain amount of training, a certain amount of guardrail controls of how it's used, a certain amount of restrictions of the use of them that are essentially enforced by the fact that the government can fund that. But one of the issues is that not every country or researcher throughout the world is funded by the US federal government or by other governments. So you don't have what I would refer to as a universal regulation and control. We try, as do other countries, the Australians, the Canadians, and the WHO in general, to set certain standards and guidelines of how you do experiments with pathogens that might actually wind up being of a danger to the human species. But the enforcement of it is something that cannot be universal because you don't have control over what can be done in a country that you have no influence on.
So adding on to that, how do you think that we can tighten up the lab security system?
Well, I think we need to get enforceable in the sense of the goodwill of nations, guidelines and regulations, and rather comprehensive training for people who are going to get involved in this type of research. You need a central authority. That's one of the reasons why I was a little bit dismayed when yet again we pulled out of the WHO. We were in the WHO for decades, and then in the first Trump administration, they pulled us out of the WHO. When the Biden administration came in, we went back into the WHO, and now we're back out of the WHO, which I think is unfortunate because obviously, from a resource and expertise standpoint, we should be and have been a major player in the company, as it were, of the WHO countries.
Thank you. I would like to once again turn to PEPFAR, the President's Emergency Plan for AIDS Relief, which you played a major role in constructing. Obviously, PEPFAR has required significant international cooperation, as it is in over 50 countries worldwide, saving over 26 million lives. Now, my question is, how did you go about reaching out to foreign countries about PEPFAR, and did they also play a role in its creation?
What seems like a simple question, Judson, but a complicated answer. The countries that were most afflicted by HIV, as I mentioned, 67% of all the cases were in Southern Africa, and 90% of them are in low and middle income countries. So early on in the in the late uh, 20, 1999, 2000, 2001, it became clear that the drugs that had been developed and shown from 1996 onward to be highly effective in suppressing the level of virus, essentially saving lives and making it almost impossible for a treated person to transmit the infection to someone who is uninfected. And so we knew that we had the drugs that were accessible to people in the developed world, ourselves, European Union, Australia, Canada, etc. The trouble is they were not accessible to people in the developing world. So we were in very close interaction, myself, my colleagues, the people in the CDC, with countries in Southern Africa. I became convinced right around the year 2000 that we should put a major effort into getting these life-saving drugs for treatment and prevention to those countries that were suffering most from HIV/AIDS. I felt passionately about that. I was not alone. Several of my colleagues felt the same way. A global fund for HIV/AIDS and tuberculosis was formed, which was a multilateral organization which really didn't address as powerfully as possible what I felt should be a major accountable and transformative effort to get the drugs to the developing nation, because we had been doing so well in the developed world with the drugs. And as I said in my memoir, when I described this in great detail, that thank goodness George W. Bush felt the same way that I did, because he had been feeling, and actually I described the details of it. He called me into his Oval Office and the Situation Room. We met it several times at different places. And the first time that he spoke, he said in almost these exact words that we as a rich nation have a moral responsibility not to have people suffer and die from a preventable and treatable disease merely because of where they happen to have been born. So he said, go back to Africa. And I already been there multiple times in collaborations that I mentioned a moment ago, and find out if such a program that's transformative and accountable is feasible in the developing world. And I did. And I became convinced by interacting with my African colleagues that this was something that could be done. And I learned a lot from our African colleagues. So, Judson, let me tell you what I learned that was so important in why and how PEPFAR was developed and became successful. The question was, if you provide drugs to people in Southern Africa? Would they be capable of taking the drugs regularly, which many people felt they didn't? I think there was a bit of a subliminal underlying racism in that, thinking that Africans couldn't take drugs as easily as well as we can. Well, as it turned out, when I examined the small amount of drugs that philanthropies made available to the physicians and the healthcare providers in Southern Africa for them to distribute to their patients in the cities and in the rural areas, I found, much to my pleasure and gratification, that they were very successful, that the people understood the seriousness of their illness and they understood the importance of taking drugs, and they very regularly and compulsively took their drugs. So the bottom line answer was, if you gave them the drugs and gave them the prevention, they would utilize it as well as people in Washington, D.C., or Philadelphia or San Francisco. So I came back to the United States and I told the president that such a plan was actually feasible and we could do it, but it would cost a lot of money. The president, to his great credit, said, don't worry about the money, let me worry about that, just put the program together. So I worked with our colleagues in the White House for months in 2002. And then in the January of 2003, the president announced in his State of the Union address on January 28th, the PEPFAR program, which was aimed initially at 14 to 15 countries for $15 billion for 5 years to treat 2 million people, prevent 7 million infections, and care for 10 million people, including AIDS orphans. And as we all know now, 20 plus years later, that program was hugely successful in the fact that over 20 plus years, it has now saved 26 million lives. So it was a combination of looking at what the Africans could do if they had resources that convinced us to put a major amount of resources so that they could amplify that effort, multifold. And that's exactly what they did. So again, it was a good example of what developing good relationships with the international level, particularly countries in the developing world.
Amazing. Were any countries resistant and or skeptical of this HIV/AIDS treatment program? And if so, how did you work with those countries when necessary?
No, they were not. They were all enthusiastic about the possibility. And the reason is it's something, Judson, that was a very emotional experience, actually, that I had when I went there and saw so many people, many young women of childbearing age and men who were just suffering and dying without any help or hope of turning the disease around. When I know in my own hospital here in Washington, D.C., at the NIH, HIV became an outpatient disease. People weren't getting sick. They were just coming in for routine checkups. So those people were suffering terribly. There was no resistance to say, no, we don't want to have a program of treatment and prevention. They were saying, please include us. Remember, we only started off with 14 and 15 countries. And there were, as you mentioned correctly in your introduction, Judson, we wound up having now 50 countries. And instead of there being $15 billion, there's over $100 billion. So there's a great deal of enthusiasm on the part of the African countries to have the program be applied in their own country.
Thank you. I have one more question for you. I
Yeah.
understand that you are concerned about current questions of scientific integrity and public mistrust. Would we be able to respond to another pandemic like COVID as well as last time? Are we prepared?
The answer is in some respects we are, and in some respects we're not. The thing that I'm very concerned about is the assault on science that we're seeing, unfortunately, at the highest levels, even from our own government. I mean, the somewhat dismantling of the CDC, where many of their most experienced scientists, almost all of whom are friends and colleagues of mine, have been fired. I mean, literally, people who are running major programs have been fired. The people at the NIH who are doing a lot of very important work have been fired. The mRNA technology, which was the bulwark of the COVID response to develop a successful vaccine, now that research has been discouraged. It's sort of like a bad thing to be doing research on mRNA technology because of the disinformation that says it's a technology that's more harmful than the disease itself, which is astounding in its inaccuracy. So I worry about that because the scientific approach that we had a year ago, 5 years ago, 10 years ago was the reason why we did so well in responding. And also our dissociation from really good, deep, and collaborative interaction with foreign countries is now no longer desirable. We've essentially dismantled USAID. We're pulling back on PEPFAR, and we dropped out of the WHO. That is not a good way to prepare for the next pandemic.
That's definitely something to think about. Thank you so much for your time today, Dr. Fauci. It's been a pleasure.
My pleasure, Justin. Thank you for having me. Take care.
This was 37th in the World, the official podcast of the Georgetown Journal of International Affairs. Please be sure to subscribe and leave a comment and rating on whichever streaming platform you use. To support the podcast, you can click the link in this podcast's description that says support the show. To read other insightful interviews and articles, please check out GJIA.georgetown.edu.